Welcome to this presentation about turning insights into impact, an engine for collaboration on health security. My name is Mark van Passel. I work at the Ministry of Health, Welfare and Sports in the Netherlands at the Directorate of International Affairs. And this presentation is made through the Joint Action Global Health Impact. So the objectives of this presentation are to explain a little bit about the Joint Action Global Health Impact, also the global health risks for health security, the tools measuring health capacities globally and regionally, and to discuss some opportunities for enhanced collaboration. So first of all, an introduction about what is global health security. We have a definition from the WHO that says that global public health security is the activities required, both proactive and reactive, to minimize the dangers and impact of public health events that endanger people's health across geographical regions and international boundaries. And currently, the global health is at a critical inflection point. Several budget cuts are weakening both international bodies like the WHO and national preparedness across the world. Unless replaced with predictable funding or innovative financing or renewed political commitment or domestic financing, the world's ability to prevent, detect and respond to health threats is sliding back. And this puts global health security at risks. So the current situation in health security is that existing health systems and structures often struggle to effectively manage emerging health threats. These challenges reveal persistent gaps in capacity, coordination, surveillance, workforce readiness, and supply chain resilience. And many countries face fragmented governance, underfunded public health infrastructure, and limited intersectoral collaboration, which hinder rapid and cohesive responses. Moreover, the lack of sustainable financing and data sharing mechanisms further weakens the ability to contain outbreaks before they escalate, for example, to a pandemic. So how can we as a global society continue to respond effectively to these challenges together? Within the context of the European Joint Action on Global Health Impact, we work to strengthen the European Union's role in global health by improving coordination and collaboration among EU member states and institutions. It focuses on enhancing the EU's strategic approach, visibility and impact in global health processes, including pandemic preparedness and response. And the key objectives within this joint action are strengthening EU leadership, enhanced coordination, communication, and collaboration. We perform several mapping and monitoring exercises related to global health security, but also to increase visibility and awareness, amongst which presentations like these. So back to the key question, how can we as a global community continue to respond effectively to global challenges together? So one of the ways to strengthen our collective resilience is to use existing tools and improve collaboration. We can make better use of existing tools. Valuable frameworks and resources already exist. They don't need to be reinvented. To effectively address cross-border health threats as a community, we should make better use of the tools that exist. And there's a wealth of knowledge, experience, and well-established frameworks available, but these are often underutilized. And we also rely on strong global collaboration. They could be increased as well. Greater cooperation can unlock coordinated action. Strengthening collaboration between countries and across sectors is also essential. And by working closely together, we can gather far more information and respond more effectively to potential risks. So there are underused opportunities for good practices. Currently, there's little focus on collecting and sharing good practices. And these are crucial for designing national health action plans, because learning from others avoids to reinvent the wheel. So where can we find this information? This information can be found in the national health strategies of each country, and key assessment tools, monitoring evaluation tools, are, for example, the Joint External Evaluation, the JEE, and the Public Health Emergency Preparedness Assessment tool, PHEPA. So what we want is to make better use of the Joint External Evaluation tool, make better use of the Public Health Emergency Preparedness Assessment, and integrating of existing tools into planning, coordination, and collaboration. Because what we don't want is to waste resources by reinventing the wheel. Every country reinventing the wheel or coming up with the same solutions that have already been explored in other countries. And that would result in duplication of existing efforts. So we don't want to create new or parallel systems. The Joint External Evaluation, I'll give you a brief overview about this, but you can of course find this at the WHO website. There's currently a third iteration. What is it? It's a voluntary WHO-led process to assess a country's ability to prevent, detect, and respond to public health threats. Why do we do this? Why does the WHO, with its member states, do these evaluations? To identify strengths, gaps, and priorities to guide investment and planning. How do they do this? By multi-sectoral self-evaluation, external expert missions, recommendations, and then following, after this process, a national action plan development. The Public Health Emergency Preparedness Assessment is somewhat different. It's an EU-level assessment framework, jointly developed by ECDC and member states to evaluate and strengthen national public health emergency preparedness capacities. And why we do this? It's to ensure countries can respond to cross-border health threats by identifying preparedness strengths, weaknesses, and opportunities for improvement. It's rather similar. How do we do this? Self-assessments using standardized indicators, peer review, facilitate dialogues with experts, synthesis of findings and recommendations, and the use of results to inform national and EU preparedness planning. And if you put this together, the joint external evaluation and the public health emergency preparedness assessment, they do share common goals, as you can see in this Venn diagram. The JEE is global. It is also outside of the EU. It's WHO-led, and it has different technical areas. This you can see on the yellow side. It's a voluntary assessment. On the light blue side, you see the exclusive elements of the PHEPA. It's only in the EU and the affiliated member states. It's an ECDC-led exercise with 16 capacities in depth, and it's mandatory every 3 years. But there are shared goals. You can see that in the green in the center. Its aims are to strengthen preparedness. It's evidence-based improvement. It's national action plans, and it focuses on cross-border collaborations. So let's go a little bit deeper into these two tools. The joint external evaluation, as you can see here, it's a WHO-led instrument. It's currently in its 3rd edition. It's a voluntary, collaborative, multi-sectoral process to assess country capacities, to prevent and detect, rapidly respond to public health risks, whether occurring naturally or due to deliberate or accidental events. It's the 3rd edition, as I just said, and it has 19 technical areas and 56 indicators. The purpose is to measure country-specific status and progress in developing capacities to prevent, detect, and respond to public health threats. Threats may be naturally occurring, they could be deliberate, they could be accidental. It also has an all hazards approach, so it also focuses on chemical and radioactive or nuclear radiation events. And the first external evaluation establishes some sort of baseline, and subsequent evaluations identify progress made and sustainability of improvements. The features are voluntary country participation, it's multi-sectoral, peer-to-peer approach. There's an external team invited to the country, at the host country. There's a transparency and openness of data and information sharing, so the reports are all made public, and there's an internationally recognized evidence-based tool. This is basically what a process looks like, and below it you can see the range of times that it'll take. So the entire process could take up to 6 months. And over here you can see that you can do first an initiation round, a planning round, a self-evaluation round, a mission week preparation. Then in blue, you see the mission week, the actual mission week, where the country presents its self-evaluation results, linkages between the stakeholders, the external team conducts joint evaluations, and the external team drafts the mission report. And post-mission in purple, which can take some time, is that the external team and the country finalizes the report. WHA publishes the report. The scoring for all those different capacities and indicators is as follows. There's 5 levels. With level 1, the lowest level, there's no capacity, to 5 level, the level 5 is sustainable capacity. The descriptions you can see in place, but they're of course color-coded, and we'll get back to the colors a little bit later on when we do an analysis of all the different JEs that have been conducted. It looks a bit like this, a scoring system. For example, the P for prevent, 1 is a legal instruments that are present in the country. And here you can see the different levels of capacity. And for a level 3, you would have the score. The country has conducted a legal analysis and identified and reviewed gaps in the health sector and developed and/or is revising the necessary legal instruments for IHR implementation at the national and intermediate level where appropriate or where applicable. And the IHR is, of course, the international health regulations the regulations at the WHO, where all member states are party to. So the JE should be seen as a platform for continuous improvement. It identifies the most urgent needs within the health system. It prioritizes opportunities for enhanced preparedness, operational readiness, response, and action. It also engages with current and prospective donors, as well as partners, including UN agencies, local and international and governmental organizations, to target resources effectively. It's the development of a multi-year national action plan. So the joint external evaluation in the WHO Euro region, as of November 2025, has seen the completion of 26 joint external evaluations. In contrast, in all 6 WHO regions in the world, there's 189 performed globally. There's currently 3 missions in the pipeline for the Euro region, for Albania, Turkey, and Moldova, but I think one of them has recently been conducted. Next, we have an analysis of the Public Health Emergency Preparedness Assessment. So the aim and objectives of the PHEPA is a systematic review every 3 years of how well an EU or associated country is prepared for public health emergencies, such as pandemics, chemical incidents, or other cross-border health threats. The aim of the PHEPA is to improve prevention, preparedness, and response planning in our countries through the implementation of the recommendations following individual country assessments. It is not scoring the country. Scores from self-assessment tools will be used to guide the discussion, but not to solely define the country's state of preparedness. It's not an audit. So the main objectives of the PHEPA are to identify strengths, gaps, and improvement areas in the 16 capacities, to promote cross-sectoral coordination, cross-border cooperation, communication, and plan testing, strengthen national systems through tailored recommendations and targeted support, to use a standardized process to build shared understanding and coordinated action across the European Union. Here you can see the 16 different capacities that are part of the PHEPA, and interestingly, the first capacity is the international health regulations implementation and coordination. And as I've indicated before, the JEE is in principle the evaluation of the IHR, the international health regulations. So there's definitely also some overlap there. This is the assessment process in a 4-phased approach of the PHEPA. Phase 1 is a desk review. Phase 2 is the country visit. Phase 3 is the ECDC assessment report. And phase 4 is the member state action plan support. Here are another table with the key differences between the joint external evaluation and the PHEPA. So the joint external evaluation is led by the WHO, whereas the PHEPA is the ECDC-led exercise. The scope is the different technical areas in the JEE, which are 19 technical areas with an all hazards approach, and the PHEPA has 16 capacities, and some of them are EU specific. The assessment cycle for the JEE is recommended to be 4 to 5 years, whereas the PHEPA is mandatory and will be every 3 years. The scoring system in the JEE is 1 to 5, with levels from no capacity to sustainable capacities, and the scoring system in the PHEPA is a qualitative methodology only. The follow-up is voluntary in the joint external evaluation, a voluntary action plan, whereas the follow-up in the PHEPA is a mandatory action plan. There's no in-depth review specifically for the joint external evaluation, but for the PHEPA, every time there's 5 capacities assessed in detail per cycle. And the geographic focus, of course, for the joint external evaluation is all the member states of the IHR, and that's therefore a global geographic focus, whereas the PHEPA is focusing mostly on the EU. So these evaluation tools generate rich insights. But most stay locked in country reports. So there is an opportunity here, and we would like to make a recommendation on this. A light touch layer could transform assessments into an engine for shared learning across member states without changing the core processes of these monitoring and evaluation systems. Over here, you can see an example. In the capacity, this is from the joint external evaluation, in the P7, which is a prevent indicator, you can see at level 2 that there is a specific indicator I've highlighted here, starting the process to monitor and develop an updated record and inventory of pathogens within facilities that store or process dangerous pathogens with toxins and what they house. This is one of the indicators within the biosafety and biosecurity capacity. And this is one of the questions that is being asked during a JAE. For example, this is the example I can give because we have experience with that in the Netherlands. In the Netherlands, we've worked together with Uganda on this specific indicator or this specific question in the JAE, and we worked together to establish a national inventory of dangerous pathogens in the Republic of Uganda. We've developed best practices, how to make such a national inventory, so that the Republic of Uganda could, in their subsequent cycle or subsequent analysis with joint external evaluation, prove that they do have a national inventory of dangerous pathogens, so that they could show that some of the indicators in the level 2 of P71 of biosafety and biosecurity has indeed been met. Over here, I give you a global overview of the joint external capacities. As mentioned before, there's 5 different scoring indicators: red, no capacity, a score of 1, up to green, 5, which is a sustainable capacity. And if you take all these 19 different capacities with all the different indicators and you map them, you can find for each of these indicators a number of countries, which I've highlighted here with the arrow on top. So if you have many countries that have a level score of 3 for surveillance, and many have a score of 1 for surveillance capacities, and very few have a score of 5, you would see an interpretation, a visualization like this. And if you plot that for all of the different capacities that are in the joint external evaluation, you could get something like this. And then you see a distribution of where the gaps are, where good practices could be, which countries are really good at some indicators, and which countries still have lots to improve. And therefore, we come to some of the conclusions. Can future monitoring and evaluation cycles include indicators capturing innovative approaches? Is there room for peer exchange sessions during such assessments? And what template changes would enable routine extraction of transferable lessons? What I mean by that is, if you go to a country to do a joint external evaluation, or if there's a PHEPA exercise taking place, would you in the self-assessment already be able to change some of the questions that you ask the country and say if they have, for example, lessons, some good practices, capacities that they're really good at, that they could showcase to other countries as a really good practice. So as a recap, the global health architecture faces different challenges: funding, fragmentation, a central player like the WHO, which is currently in a big reorganization. And there are national health capacities that rely on general agreement, which are, for example, written down in the joint external evaluation or in the PHEPA assessment tools. These monitoring evaluation mechanisms assess capacities, but they do not foster collaboration between countries yet. But with small tweaks, good practices can be extracted and shared. So we hope that in future cycles of the joint external evaluation or in future cycles of the PHEPA, the ECDC and WHO will find ways to tweak these tools a little bit to also not only look into the gaps that countries experience, but also look into the good practices that they have and find a way to share that with different countries to foster further collaboration and cooperation between different countries. That was a presentation. Thank you very much for your time. And for any questions, you can visit the website of the Joint Action Global Health Impact on the link indicated below. Thank you very much.